Good morning, ladies and gentlemen. At this time, I'd like to call the meeting of the Select Committee on PEIA Seniors Long-Term Care to order. Chair looks to the clerk for the purposes of taking a silent roll for the establishment of a quorum. Quorum being established, the chair looks to the co-chair for the purpose of a motion.
Mr. Chairman, I move that minutes for the meeting held April 24, 2022 be adopted.
Co-chairman Azinger moves that the minutes from the meeting of April 24th, 2022 be approved. Are there any additions or deletions?
Nope.
None being seen, the gentleman's motion is before us. All those in favor of the gentleman's motion, please signify by saying aye. Those opposed, no. The ayes appear to have it. The ayes do have it. I declare the gentleman's motion adopted. As the members of the committee will remember, we had this presentation from PEIA at the last meeting, and we just had enough time for the presentation. So we're going to start out with questions on the presentation from the last meeting, and I hope everyone brought their packets with them. If they did not, I think we can probably provide others. No, we can't provide others, but I do have a lot of questions, and I'm sure you do as well. And then at the end, there's another presentation that is in your packet regarding interim committee, and that's going to deal with pharmaceuticals primarily. So with that being said, are there any questions of our, well, I guess, council, do we have to swear Mr. Hott in again? Yeah, okay. Our guest today is Jason Hott, who's the interim director of PEIA. Mr. Hott, as customary of the legislature, we do need to swear you in again. Do you swear or affirm that the testimony you're about to give is the truth, the whole truth, and nothing but the truth? So help you God?
I do.
Okay. Then do we have any questions of our presenter from our previous meeting? And if not, I'll start out with some to break the ice here. Do you have a copy of your previous presentation with you?
Yes, sir.
Okay. Going to page 2, you talked about the pay-go premiums, and I would like a little further elaboration of that, and perhaps you'd mentioned that once it was 105% funded, we no longer needed that charge. So could you explain some about where the funding's at? And I think you said that we are 105% funded, or will be.
Yes, sir. We're a few years out, 2 to 3 years out of being at the 105% funded level. And the pay-go, back in the late 70s, as retirees were joining PEIA, the board added additional premium to the active premium to help offset the cost of healthcare's increases on the retirees. And so that active premium was increased to fund the retiree healthcare costs, to help keep their retiree premiums lower than the actual cost of the healthcare being provided.
And I believe for the state, at least on the presentation, you had right at $60 million. Is that so? And I think you'd said that at some point before too long that might go away.
Yes, sir.
So do you accrue that like an OPEB?
This is the actual funding of the OPEB. Then there's also an additional accrual entry only for the liability. So it is, they're related, but this is the actual payment, and the liability booking on the financial statements that the agencies do is a separate entry. And we're looking good on that aspect too. That's the, it is right now, the last OPEB valuation report indicated that the fund is going to be an asset on the accrual for the agencies.
So what have you accrued in that fund that will backstop this OPEB?
The balance in the OPEB plan right now, I believe, is about 1.6 billion.
And so your plan would be eventually that part of the OPEB would be paid off of the earnings of this accrual.
Yes, sir.
Now, are those segregated, that $1.6 billion, is that segregated assets?
Yes, sir.
So it strictly goes for the pay-go only?
Yes, sir.
Okay. And at what point would you, so you've got 1.6 billion accrued. What is the magic number that you need to get to say that this is fully covered through the OPEB?
The most recent policy is that we're going to, at 115% funded, call it funded. And right now, I'm ballparking probably that would be around $1.8 billion to $2 billion of assets to deem the OPEB liability of 115% funded. Once we're at 115%, we'll then be able to absorb any bad years in the market or bad years in healthcare trend and not have to restart funding the program again. So 115, I think they're looking at about 2027 is where we might be able to hit that 115%.
And so at that point, this 60 million would accrue back to the state?
Yes, sir. Actually, the 60 million will come back to the state at 105%. That's the pay-go. What we'll achieve when we reach the 115% funded level is the state won't be required to fund a supplemental payment of the $30 million that's currently going into the RHBT fund right now to help supplement the OPEB cost, OPEB liability.
And that 30 million is in addition to the 59 million?
Yes, sir.
Okay, so it's even worse than the 60 million. It's 60 plus 30.
Yes, sir.
Okay. If no one else has any questions, I've got several. Still on that page from the last presentation, you've got it segregated to the state fund and the active local fund. And you go about 2/3 of the way down, and fiscal year results show a loss on the active local of 23 million. I was at least under the impression that was not supposed to occur, that the local agencies were supposed to pay the full freight for what the premium was, and then they would decide how to portion out the premiums to their employees. Explain the $23 million loss.
The $23 million loss, sir, is being absorbed by prior year gains in that fund. That fund's positive returns in the prior years have created a reserve in which the board determined to pass the finance plan to utilize the beginning plan reserve of 53 million, which was more than the actuaries require. So they're using those prior year gains to offset that loss.
So you spent down in this fiscal year about 45% of your reserves.
Yes, sir. It goes, looks like it goes from 53 to 30 million.
Well, looks, and this ending premium stabilization reserve of 7.8, is that an additional accrual that you plan on making this year?
No, sir. What we do here is for the viewers, when a viewer looks at this form, they can ascertain the minimum actuarial reserve. That's the statutory minimum actuarial reserve required by code. And right now, the actuaries have that at a 14% of expense level. And so anything over that 22 million is the premium stabilization reserve that is a portion of the reserve that may be used to offset costs in the future.
So in other words, you can't touch the 22 million.
Good. Yes, sir. That's correct.
So really, after this year, you've spun that down to where you've only got 7.8 million of additional funding that could offset.
Yes, sir.
And so you're getting you're spending most of it this year. Is that a correct statement?
A good portion is being used this year, thus the 5% premium increase that was passed for 23, the upcoming fiscal year.
So we are going to charge the local entities the true cost of their premiums.
Yes, sir.
Okay, going forward.
Yes, sir.
Is there any plan to accrue, but I guess you don't need to accrue past the 22 million. Is that correct statement?
That is correct.
Okay. On page 3, if you could perhaps talk a little bit about the ability to pay premiums and the tiers, and if you could talk a little bit about those, and perhaps do we have plans to change the tiers, or a little elaboration on the tier method?
Sure. So right now, there has been a policy executed by the governor for 23 to increase the current salary tiers by $2,700. And really that helps index the salary levels for when there's across the board salary increases. So these are set to, there used to be, I think at one point, 18 index code. About 10 years ago, they were cut down to 9. And, you know, the policyholder's salary as recorded by their employer in the state fund is what determines where the policyholder falls into these salary tiers. And the 41 to 47 is generally the median, with probably the bulk, I believe it's in the second level index code. That 25 to 35 is where the most folks are. The ability to pay methodology was deemed to be the salaries of the employees years and years ago by the PEIA Finance Board, is how that's determined an ability to pay. And this also impacts their deductible and maximum out-of-pocket levels on their benefit side too.
Okay. So if I heard you correct, then across the board, each tier is going up $2,700?
Yes, sir.
And that's effective this year or next year?
August 1st, 22. So next fiscal year.
Okay. Okay. On page 7, there's a line for life insurance up on the revenues. Is that something the state administers, or is that a third-party agency that you're simply collecting a premium and remitting it on? It is
a pass-through premium to the life insurance carrier.
Okay,
yes,
so that's optional to the employee?
Yes, sir.
But there's no state exposure?
The only state exposure is on the active side on page 3, slide 2. The state does participate in the basic life. So in 2022, the state's currently collecting $2.2 million for basic life premiums that are also handled in the same manner by the carrier handles.
Yeah, okay, but when you say participate, does that mean the state is assuming the risk, or we're just paying part of the premium to the third-party vendor?
We're paying the premium, yeah, okay. and it is carried by the.
So there's no assumption of risk by the state. We're not providing life insurance in addition to health benefits.
We're providing it, but only as an administrative.
Yeah, well, we're not the assumption of risk agent.
No, sir.
Okay, okay.
We are non-participating, I believe is the term in the life insurance.
When you go on down program expenses, gross non-Medicare prescription drug claims. Now, one question I had with the retirees, once someone retires and goes on Part D, or do they have to take Part D, or how does that work with a PEIA retiree?
Once an individual gains Medicare eligibility, we treat them as having Medicare as their primary insurance.
Right.
And so if they don't pick up B or if they don't pick up D, then it's going to be to their cost to not have us participate.
And I think you said something about the amount of the subsidy is by years of service.
Yes, sir.
Explain that a bit more if you could, perhaps.
So the individuals that were hired before July 1st, 2010 may take their credited years of service at CPRB and exchange that for a subsidized healthcare premium with PEIA. So if they had 5 to 10 years, they get a little bit of a subsidy. 10 to 15, get a little bit more, 15 to 20, and then the 20 to 25, and then the 25 or more years of service, they get the greatest benefit level. And the majority of our retirees are in the 25 or more years of service category.
Okay. And does anyone, I hate to ask all the questions, but I've sure got a bunch more. Delegate Reed, because I'm not done, but we'll share the podium.
Thank you, Mr. Chairman. Yeah, I want to go back to the Part D as the primary once they retire. Is there a reason why we're funneling everybody into Humana? Do they have a choice? Can they go on the portal? As you probably know, the Medicare Part D is very individualized depending on what medications they're on, how much money these people can save, but they all seem to be rolling right into Humana.
So they are eligible to participate in PEI's MAPD program if they choose to be in PEI. They obviously don't have to. They can go to the open market and pick up a Part D plan if they wish. But our package includes both.
Do we subsidize any of that for the Humana? What's the return on investment for doing that?
So the return has been huge. We were able to, when we first implemented the MAPD program with the plan back in 2008, I think the state saved approximately $100 million right off the bat on costs to the OPEB liability. It was a tremendous savings, and to date, we're down to 63 million in Humana MAPD capitations, which has been a huge savings. And from our perspective, it has been a really good financial move, and it's been able to keep our benefits at a very respectable level for our retirees, Medicare retirees, excuse me.
Okay, thank you.
Any other questions? Delegate Tully.
Thank you, Mr. Chairman. Thank you for being here. Are you familiar with anything that has passed in the Utah State Legislature where they're allowing their state employees to shop for services as far as healthcare services and they do some rebating if they're able to find lower prices? Actually, the refund goes back to the members. Have you looked at any of that in relationship to anything that would be possible within the state?
I'm not familiar with the Utah program, but I do understand it's that concept, reference-based pricing, et cetera. It's very has been becoming more and more popular in the healthcare industry because it exposes the members to the cost of care. And our Part C is a high deductible plan, which is intended to help, give an incentive to folks to do that very thing and shop for services. We have, as far as the transparency that's been required law that's been passed at the federal level, we have a tool on our UMR, which is our TPA's website, where our members can go out and look at a particular service and look for a particular provider that provides that service and get a rating, both cost and care quality. We talked about it during our last public hearing, and we're really hopeful that our members take advantage of that tool. Now, as far as actual costs that we give incentives to the members, That would only be, there's really not a lot of incentive due to our reimbursement setting. So there's not a lot of variance, but as far as in-state, out-of-network, there's a lot of variance. So in that regard, yes, we do steer our members to more affordable healthcare providers within the network or in the state.
I just wonder if it would be something worth like exploring or looking to run some numbers to see if it would work, any type of concept like that, what they're doing in Utah would work for some of our members. And you're absolutely correct. I think anytime that any patients can be exposed to what healthcare costs and to kind of learn how to manage their costs and get the highest quality of care for the best price, I think it makes a more educated consumer of healthcare. So
Thank you. I will look into that program. Thank you.
Okay. I got a couple more questions, probably one of which I'll wait until after you get into this presentation today. But if you go back to the part from the previous presentation, plan statistics, and go to page 14. On the top, you had admissions per 1,000, and it would appear as though we do not very well. We're a little above the norm. Would that be a fair statement?
Yes, sir.
Our length of stay was within a few decimal points of about the same. But our paid per admission, if I'm looking at this correctly, we're 53.2% below UMR's, who is our third-party administrator.
Yes, sir.
We're more than half below their average paid per admission. Is that correct?
It is, sir.
Now, could I surmise from that is either our patients aren't as sick or our doctors are super incredible, or could I surmise that it's because our reimbursement is tremendously lower than what UMR's typical reimbursement might be?
It is the latter, sir. It is the reimbursement.
Okay. Could you give me an idea of how much below UMR's typical fee schedule our reimbursements to hospitals would be?
I would think this is probably a very
Okay, so we can
good
surmise that then
representation.
you're saying we're paying about, to the hospitals, we're paying about half what UMR would normally pay.
I would think so. Yes, I think that's a reasonable estimate. This does have both in-state and out-of-state utilization.
So our in-state would even be worse?
It could be. Yes.
So because if my understanding from previous presentations was our out-of-state, we were paying UMR's typical fee schedule?
Yes, sir.
So our in-state providers are probably getting somewhere maybe a 60% cut from their normal reimbursement?
Yes, sir.
Do we have any justification for that?
My understanding as to the justification was the hospitals in the state determined it be a reasonable means to save the state money and also allow for a matching of dollars that PEIA provided to BMS, or Medicaid, to then get a match. So it increased their reimbursement at the time it was agreed upon in 2002. Many folks refer to it as the Medicaid swap. And then it was allowed PEIA to further reduce their discount. So my understanding, sir, the justification as to the level of reimbursement by PEIA to in-state hospitals was an acceptance to take a lower reimbursement to help save the state dollars in the cost of health care to the state of West Virginia.
And, okay, so how much money annually was involved in the Medicaid swap?
PEIA gave 7 and Medicaid received 21, so it increased their reimbursement approximately to about half of that after PEIA took their discount. So I think they got about a $14 million discount, and I believe the state also, outside of the PEIA dollars, started accruing additional dollars into that matching process that I believe is called the supplemental funding, which is paid quarterly by the Medicaid programs. So I'm thinking that eventually it ended up being a gross reimbursement of almost around $40 million add to the state reimbursement at the time.
If that's the case, how are we still paying 60% discount to UMR's typical schedule?
Those dollars aren't included in PEIA's reimbursement. They're outside of PEIA's payments. They come
How are they distributed?
through the Medicaid supplemental payment program, is my understanding.
So if you took UMR's fee schedule based on the volume of work the hospitals are doing, and you discounted that 60%, which is in essence what we're doing, do you have any idea how much money we're talking? What's the annual give back that the hospitals are doing? Is it just this 14 million, or is it much larger than that?
I would assume it to be larger than that.
Do we have any idea of how much larger?
I'd like to do some research on it.
I trust you get back to the committee with that.
Yes, sir.
number.
I can definitely get a gross allowable and then the discount taken.
Okay. And I noticed going on down that sheet, it's the numbers are even more gruesome when you get down to emergency visits and kind of on down the line. Is it a fair statement to say that our reimbursements are pretty substandard compared to what UMR's normal rates would be?
They are, and that's, as we've discussed, primarily due to PEIA's lower reimbursement on the inpatient. But actually also there's a factor of West Virginia's actually is blessed with, we do have lower cost hospital rates in state, even compared to our bordering county. So that also contributes to a national look at UMR's book of business rates, in addition to the reimbursement levels.
Okay. Well, I've got a few more questions that were from the back, but it directly deals with pharmaceuticals, and I think that's where you're headed. So with that being said, I think Delegate Pack. Sorry, Delegate.
Thank you, Chairman. Just a couple questions. On your key indicator screen, which is very helpful information, could we get the information that would show the pay per admission amount for both in-state and out-state hospitals?
Absolutely.
So going to Chairman's point that we could understand what that looks like.
Absolutely. Yes,
and the next question is, understand 20 years ago that hospitals and I guess the state made a deal 20 years ago. Of course, a lot has changed in healthcare in the last 20 years. But is it fair to say that the PEIA is currently paying hospitals less than their cost to provide these services?
That has been spoken by the hospitals that the state is reimbursing below. Yes.
Okay. And it's also fair to say that Medicaid is reimbursing the hospitals less than cost.
I have heard that. Yes, sir, that they are.
Okay. So even if there was a deal 20 years ago, maybe it made it a little bit better at the time, but the result today is 20 years hence that hospitals are being paid below cost for both Medicaid and PEIA. Therefore, we really are putting a huge burden on the hospitals in West Virginia.
Yes.
Okay. Thanks, sir.
Okay. Any other questions before we move into the interim Delegate Tully?
Thank you, Mr. Chairman. And so, Mr. Hott, is it fair to say that are all of the in-state hospitals reimbursed at the same rate through PEIA?
There actually are slight variances because this PEIA uses a very complex reimbursement model known as the DRG, in which it takes the literally dozens of factors that we receive through the CMS, and each time it updates. So WVU could get a reimbursed a weight for a knee surgery of X amount, and then say Cabell could get reimbursement at X amount for the same procedure. So there are percentage differences as to how much each hospital receives each year. So there are variances on how much a knee surgery will be paid at WVU versus Cabell based on the factors CMS receives through their reimbursement update program.
Okay, so like all your RVUs, your relative value units and all that,
Exactly.
that all factors in.
Not huge, but
But-
there are differences.
Some variance. So how much does quality factor in with PEI and reimbursement rates to the facility? So are we paying essentially roughly our best performing hospitals the same we're paying as our bottom performers? I mean, is that accurate, or is there any differentiation for quality?
I think it is accurate unless the CMS weighting does include any types of penalties for, say, a higher than normal infection rate, readmission, et cetera.
CHF,
So they're deeming
MI,
them
whatever.
and their weighting and attributes that set the rate weights, then yes, those would be included, but I'm not aware of PEI then taking it and making an additional penalty of any sort.
And I don't know if it necessarily would be a penalty, but if we consider any rate increases in the future, I know they were asked for during the last session. I kind of wonder if it wouldn't be prudent to kind of look and see where our best performers are, and especially in some of the high volume areas of the procedures that they do and that sort of thing. That might be something to explore. Thank you very much.
Thanks.
Senator Raysinger.
Thank you, Chairman. Stroud, quick question here. Of course, taking less than cost is a bad business model. Do these hospitals, are they required to take PEIA and Medicaid? And do they have to take Medicaid?
Oh, I'm not sure about
Or-
Medicaid.
or
I'm sorry.
Medicare.
For PEIA, they are
But
not.
PEIA, they are not required.
sir.
Okay, all right, thank you.
Okay. No other questions being seen. If you'd like to move into your interim presentation, we anxiously awaited.
All right, thank you, Mr. Chairman. So this was an interesting project. Interim committee staff had asked if we could break out PEI's benefits on a mandated basis versus an optional benefit basis. And we've never really looked at it in that regard. So it was an interesting exercise. And what I found once I got into it is it wasn't objective. It wasn't black and white. The terminology in the code sections use major medical, major surgical. So there was some discretion, there was some subjectivity into dissecting the benefits into two separate groups. And I wanted to start with the optional coverage because right off the bat, I didn't really agree with DME being an optional benefit. I can't imagine any major medical plan being released that doesn't have DME. But again, this was trying to take your perspective of what is mandatory versus what is optional. So right off the bat, I'm questioning the 11.1, and I'm sure some of the attendees in this committee meeting may also question some of the others. But for example, the massage therapy. There's nowhere in the code section that requires massage therapy, but due to various issues within the state regarding means to avoid opioid prescription, anything that could keep somebody from possibly being exposed to addiction, we and our in liturgy available massage therapy was incorporated into the benefit program to help folks receive treatments for any back pain or chronic pain that they may be receiving. Bariatric procedures, speech, cardiac pulmonary rehab, hospice, dietitians, chiropractic, sleep management. Those are some of the items that were captured for the benefits in which could possibly be considered an optional benefit that PEIA provides that may not be technically required per the West Virginia State Code. So then slide 3 also shows it in a pie basis. So it's a lot of money, but in regards to the overall spend of the plan, not a material portion of the PEI spend. So moving to slide 4 is where we then start getting into what we would deem the mandatory care categories, where we would be required per code to provide to our membership in the benefit package. And there was some interest in looking at this on a map basis. So this is a representation based on patient address of the utilization by patient address. So you can see right off the bat where our population centers are in relation to where the state agencies are, where the county boards of education are. Their higher percentages or higher utilization is going to be in your Charles Kanawha County, up in Eastern Panhandle, the Morgantown area, the Cabell County area. This is basically showing where the people are coming from that are creating the cost for PEA. Slide 6 is then a pie chart of the top 20 procedure types, procedure codes, or diagnosis categories of the mandatory. So looks like our biggest pie slice here is exposure or encounter screening or contact with infectious disease at 14.7. And this is the state fund only. You then have encounter for antineoplastic therapies, cancer treatments, medical examination evaluation. I believe this is where all of your office visits are going to. Your 99213 through 99218, I believe, is the range for E&M. Spinal, I'm not going to try to pronounce that. SPOND, but that's your spinal treatments. A lot of back osteo procedures. Again, cancer, neoplasm-related encounters, cancer, osteoarthritis, then coronary atherosclerosis, and other heart disease. A lot of money spent on cardiac treatments in the plan. Musculoskeletal pain, lower back pain, 4.9. Abdominal pain, 4.9. And septicemia, 4.7. So that's a pie look at our top 20 mandated benefits. And then slide 8, we get into the pharmaceutical, much similar to the medical when you look at the map. It's your membership treatments of medical and RX. It's almost a mirror image. A little bit of difference in some of the shading in some of the counties, but very similar. And so the next slide, on slide 9, is looking at the top prescriptions by therapeutic class. The anti-diabetics is something the plan has been seeing for a few years now. The cost of diabetic treatment prescription drugs has just really increased. You can see it's almost at least probably a third of the pie. And then the remaining top therapeutic classes as you go around: analgesics, anti-inflammatory, dermatologicals. So you got your insulins and your diabetes treatments in the blue. Then you got your Humiras, your Enbrel, specialty drugs. Specialty drugs have caused some of the greatest cost increases, not just PEIA, but across the nation, on all the healthcare costs across this country. And it was interesting when we were researching the next slide, we got back into 2002, 20 years ago. During our research, we found in a report where we were predicting the increase in costs due to specialty drugs. And unfortunately, those very scary looking projections have come true. We are exactly where we thought we would be as far as the percentage of spend in our pharmacy benefit in relation to specialty drugs. It was amazingly accurate. And that is reflected in the next slide. I was asked to show over a 20-year span all of our major categories as far as inpatient, outpatient, professional services, and pharmacy, and what the percentage of pharmacy is in relation to the overall spend. And as you can see, from 2017 to 2022, with the pharmacy now represents 40% of PIA's total claim costs. 20 years ago, it was 30%. So the price of drugs has just really skyrocketed, and mostly specialty has created that since 2017. Almost the entire trend can be pointed to the specialty drug class in our benefits. Now, I will point out, as I put in parentheses, this is gross cost, but we're looking gross to gross over the 20 years. We're going to get back over $100 million in rebates from this 2022 number, but it shouldn't, but it's still, that's where the price is. That's a problem. And we are faced with some difficult discussions when it comes to affording your benefits when you see these types of increases in your costs occurring. So that concludes my presentation, Mr. Chairman. Happy to take further questions.
Any questions of our presenter? Delegate Tully.
Thank you again, Mr. Chairman. I want to go back to your slides on page, I think it was 6, I believe. And I see like you have the exposure encounters and screenings for infectious diseases. How much of that includes COVID-19? Are you aware of that? Are you aware like where the breakdown would be?
I wouldn't, and I would imagine that would fall into respiratory, but I can check and see how the data manager grouped these categories.
Because I think that would be interesting, because if you're coding that like, with a Z code when you're doing your billing, a lot of that for 2020 and 2021, of course, would be much more elevated than what you would have ever seen before. And are we expecting that to trend down? And that's the other question. If it's for, maybe hepatitis B, if there's a breakdown that we could get within that range to see where that total is coming from.
Absolutely. And I will also, if I may, after the committee meeting, I believe the last presentation does have a respiratory blip where you can see the COVID respiratory diagnoses coming through.
Okay, I was just curious with that total and to see if maybe we could expect that to trend down as, some of the exposure and the testing isn't being done. Thanks.
Any other questions of our presenter? No, I've got several. Oh, I'm sorry, Delegate Reed.
Thank you, Mr. Chairman. I actually have several myself. Going back to slide or page 3, that DME number, that 11 million, does that include the actual administration costs for the COVID-19 immunization?
I can get that breakdown.
I was curious why that number is so big. And going to,
pardon me. Well, just clarification, this is medical.
oh, that's on the medical side.
This
Okay.
slide 3 is medical, yes, sir.
Okay. All right.
So that's your neck braces, that's all the DME.
Yeah, but why in the pharmacy world, though, we have to submit the COVID immunizations on the DME side.
Oh, okay.
So that's why I'm curious to whether or not on the outpatient side.
Okay, I will confirm that.
Okay. On 6, I'm gonna follow up on her question on the infectious disease for the 14 million. How much of that is HIV and Hep C in the PEIA world? And is that related to the corridor between Canal and say Huntington?
Okay.
And then we're going to get into specialty drugs once again. How do you see us being able to drive specialty drug costs down? How do you see PEIA being able to drive it down? So from 2017 to 2022, what we have done isn't working. How do you see PEIA driving that cost down?
Individually by itself, sir, I struggle to see how our 230,000 lives will make a difference to the specialty drug manufacturers. However, the current strategy is to leverage the volume through the PBM and or work with local providers that are willing to pass on their discounts that they receive that might be greater than the ones achieved through the PBM purchasing power.
So now I've got a suggestion. So after the last meeting, I drove home and I was thinking about the whole big picture. 20 years ago, it came down to incentivizing generic competition. Drugs were relatively cheap back then. The brand came out, they made their money, they had a patent on it for 7 years. The generic came out, they had a patent on it for 6 months for exclusivity to kind of juice that program. And then after that, tons of generics hit the market and the prices dropped. What has happened in the specialty drug market is that we are arbitrarily keeping these brand name medications at the top of the list due to these rebates that we're addicted to coming back in on the back end. So it never allows that generic competition ever to take hold. And in the meantime, the generic pharmacy companies have all been bought up by the brand name companies to exacerbate that problem. So maybe we should look at trying to incentivize generic competition at a state level or maybe even a national level again to drop these prices that are occurring at that level. In my world, the state of West Virginia made it illegal for pharmacies to take rebates because they thought it was an unethical part of that for me to be able to switch people to more expensive drugs than move them toward less expensive drugs. But the state seems to doesn't seem to have that problem. They're basically doing what they made illegal for the pharmacy level do at this level. The state is actually doing it at this level. They are maneuvering people into more expensive drugs to get that supposedly rebate back, but it's causing that extremely high move for new drugs to move into the specialty drug arena because there's no such thing as a specialty drug. It's just expensive drugs. And we all know that. But I was curious to see whether you had an idea on how to drive those costs down going forward.
Yes, sir. So as a previous statement, right now it's purchasing power, but I would like to get away from that because, as you say, at this point, it's not been effective.
Now, it's causing the problem. It's what it's causing, because then you only have 1 or 2 drugs on the market and you're not going to get any more because there's no incentive for generic competition at this point. There's a generic insulin on the market right now that nobody's going to use because you got this rebate supposedly coming back, which then stops other companies from making that generic insulin, which then would drop the cost. Insulin used to be, I used to sell for $9.99. Now it's through the roof because they have this rebate system in place that you guys cannot get away from. So I think that's what we're trying to do. Now, this is across the country. It's just in West Virginia. But I appreciate your answer for that.
Thank you.
Doyle.
Behind the mask.
Mr. Chairman, I'm supposed to have surgery here in 2 or 3 weeks, and I don't want to get COVID and have to postpone the surgery.
Certainly understand, Delegate.
But I will take it off the top. To follow up on Delegate Reed's question, is it possible that you folks at PEIA, and I'm dealing with the fact that it's a national problem, can collaborate with your sister agencies in other states, and that would give you the clout?
Yes, sir.
Good. I encourage you to do so. Thank you, Mr. Chairman.
Okay.
Absolutely.
Any other questions? If not, I've got a couple more. First of all, I would like to compliment you. I believe at our last meeting, I'd task you to put together this chart that's on the very last, the 20 years. And I think it's pretty telling in a couple things. First of all, as expected, the pharmaceutical spend has just went out of sight. But secondly, it also shows that our inpatient spend has basically flatlined. And I would hope we'd agree that the cost of providing care at a hospital has increased substantially in the last 20 years, but our spend has kind of flatlined. So maybe that further substantiates your testimony already to date. But a couple things I'd like to talk about. I know that several constituents have reached out that they've received letters that their pharmaceuticals are going to be switched with the next plan year because I assume that there's been a change in your formulary. Now, is that change in formulary, to get back to Delegate Reed's question, is that driven more because of rebates or is it driven more because of efficacy? Hit your, please, I'm sorry, gentlemen.
My
Yeah.
apologies. Thank you. My apologies. I would, based on my experience, I'm going to say that it is based mostly on the finances of the drug that they're putting on that formulary in regards to, and in relation to the efficacy. If the efficacy is found to be of similar levels, they're going to go with the formulary drug of the same clinical efficacy that gets the best net cost for the purchaser. So the switch between CVS to ESI, assuming both of their formularies have the same clinical efficacy for that therapeutic class, you have to assume that ESI is getting a better deal for their formulary brand drug that's changing from CVS. So it would mostly be the cost, I would assume, in this switch, sir.
So it's all through the PBM.
Yes, sir.
Is what I'm hearing. Is our plan big enough to contract directly for some of these really expensive medications?
Not at the same price level. I would not think so. No, sir.
And we've researched that and found that to be the case?
Yes, sir. We have done competitive solicitations with our plan. No pricing options have been received that gives us a better deal than the methodology that we're currently employing.
Which is to
the PBMs.
Pay, and the PBM's model is to pay the full price and then get a big rebate back on the back end.
Yes, sir.
So what does the patient or physician, if they're taking a medicine for cancer or diabetes or whatever the ailment is, and they're well controlled, they're doing fine, and suddenly this letter has showed up in the mail that says that you've got to switch the 1st of July. What's their recourse? Or is there any?
There is. The plan does have an appeal process in which the member does have the opportunity to appeal that they shouldn't be moved and be allowed to stay on that non-formulary drug at the formulary cost level.
And are those appeals successful most of the time, unsuccessful?
Yes, sir, they are. We gathered those statistics during the public hearings, and I can revisit those, but there is I believe a higher than more than 50% appeal granted for that to stay on the formulary level.
So 50%.
Yes, sir.
So the other half are just denied and they either pay the difference or move on.
Yes, sir.
Okay. In regards to specialty drugs, I mean, a lot of that is either going to be in the biologic area or the anti-neoplastic area. Is that a fair statement? Or perhaps, well, I'll take that. With Hep C, you've got pretty expensive medications there. So antivirals.
Our biggest cost, I believe, our top are the Humiras and Enbrels, I believe, are
the biologic agents. So I know a lot of times those are to go through a specialty pharmacy and there's a 340B pricing involved, some specialty pharmacies over others. Does the state have any access to 340B pricing at any of these pharmacies?
Not except for PEA does have some direct contracts with a couple of 340B pharmacies that we have arranged where the pharmacy has agreed to pass on to PEA a discount in order to attain that utilization of member care. So not widespread, but there are there are, I think, 2 or 3 contracts we have right now with 340B's pharmacies.
And what would the magnitude of those savings be?
I don't have a total figure off the top of my head, but they do generally beat the guaranteed discount rate from the PBM. Let's call it 15%. They'll come in and say, well, I'll give you a 20% discount for these same drugs, for as an example. But I don't know what the actual value is at this time.
It's substantial.
Absolutely, because due to the cost of the drug itself, it's a lot of money.
Would there be a reason to perhaps look at, and so the patient is getting the identical medication?
Yes, sir. That's my understanding.
Yeah. So would there be a reason not to switch for the specialty drugs? Would there be a reason not to switch all of our recipients to the 340B pharmacy?
The only thing that I would see is the possibly capacity or location and availability to handle the logistics, but financially, no. As long as everybody's on the same page and agreeing what the rates are and how it's going to work, it's not out of the realm of possibilities.
So we haven't signed anything in our PBM agreement that would prohibit the use of a specialty pharmacy not associated with that PBM.
The contract that is to be signed does have the PBM providing specialty pharmacy program services. But, you know, everything's on the table, though, if we decided that we needed to switch gears, sir.
So we have not executed that contract yet.
No.
So if we looked at, say, an in-state 340B eligible pharmacy to provide our benefits, that could be a substantial savings to the state of West Virginia.
I would not call it a savings, but I would think we could possibly match, or not have a large material loss in the transaction. It could be explored. Depends on what the provider is willing to give in a discount for that 340B drug would be the bottom line for that specialty drug.
Okay. I would hope that perhaps we could look into that before we execute the agreement.
Okay.
But okay, that. Are there any other questions? Delegate Nelson? Senator Nelson. Senator, I'm going back to the old days. I think there's a little, you just did it.
Okay, just.
Senator, you're magic.
Just a piece of clarification on that last chart. Over the last 5 years, I mean, that trend is vertical almost. What has been the trend in rebates over these last 5 years?
The trend in rebates has tracked with this.
So we do a gross, or you've presented a gross number here. To back out the rebates and look at the line less the rebates, I think is more of a bottom line cost to us as a state that would be appropriate to look at, would it not?
Oh, absolutely.
Yeah.
Yep.
And last question, the timing difference. So what is the timing difference as it relates to our payment for a drug versus the receipt of a rebate?
So they vary by manufacturer and the contract with the PBM. So some can turn around in 30 days, some could be 60, clear out to 120 or 150 days. What we have developed in our financial reporting is a receivable based on utilization of the drugs. When we spend money on that drug, we then book a receivable based on the guarantee and actual experience of the rebate. So we're always having a quarterly payment coming in that has continued to increase just with these costs that are reflected on this bar graph. And there's generally a trend of quarterly payments that continue to increase And I would venture a guess of 90 days is the average utilization and return on rebate payment would be my guess, sir.
So as an industry, why aren't we dealing in net numbers? I mean, when we buy an auto, it's a net deal. We don't wait 90 days to get a rebate from GM or Ford.
So what you,
In your opinion?
in my opinion, you have the ability of a manufacturer and a PBM to set a cost much higher than the net cost, so that anybody that's not like PEA or Blue Cross Blue Shield or Aetna or United that has this large volume of purchasing power and cannot leverage their weight in a contract to say, well, this is how much we're going to give you in rebates. And they're going to keep that margin. So they've got more room between their cost and their actual list price. List price is extremely high to give them more flexibility in their contracts to assure that they're getting the profit that they need to get for their drug sales. That's my thought.
Thank you. Thank you, Mr. Chairman.
Delegate Tilly.
Thank you again, Mr. Chairman. I want to go back to the formulary swap that was mentioned, or formulary change that was mentioned a minute ago. So you mentioned that there's an appeals process and 50% of those appeals are successful as far as, getting that patient back on the drug that they were originally on. What happens if there's no alternative to that drug and that drug is still denied?
Well,
If it was on formulary, it goes off formulary, they go say the patient or provider goes through the appeals process and that's still denied. What happens with that?
there should not be that situation, ma'am. We should not ever have a formulary. We can't release a formulary that doesn't have all therapeutic classes covered in some level, some tier of copay or cost.
And what happens if they fail step? Is there a step therapy process for your organization? And how burdensome is the documentation, not necessarily for the patient, but for the providers that are tasked with doing all of the documentation with that? Because sometimes that can be a pretty heavy burden if you're trying to run an office, take care of patients, see patients, and then you've got stacks of paperwork, particularly if,
I'm not familiar with it myself, but I have heard complaints about the necessary steps that you have to go through in the step therapy process overall.
Is there any way that we could look at streamlining some of that for the providers and trying to work through that? Not necessarily, and hopefully not increasing our costs, but to make it as painless as possible for those providers and to save some time and let them see their patients rather than completing paperwork.
Absolutely.
Thank you.
Okay. Okay. Lastly, Delegate Reed.
Thank you, Chairman. I just have two questions. The first one is going to follow up from Delegate Tully's, is that who actually does the appeal process? Does PEIA do that, or is strictly the PBM?
The first level for sure is PBM. I think, Delegate, there is on the drug side, an independent review possibly also available if after the PBM review, but let me follow up on the exact process on that step. So that appeal.
Okay. And my last question, you piqued my interest with this 340B talk. The pharmacies aren't the entity that run 340Bs. It's usually the providers that become a 340B provider. So you're telling me that PEIA is a 340B provider and they can contract at 340B prices?
No, sir. No. We have agreed with 340B providers at a certain price for their drugs that they're offering through their pharmacy.
Okay. And does PEIA have a list of the 340B providers or who are eligible? Because it's the patient themselves that become eligible, not the provider. And it's based on income.
Yes, sir, we do not. And that's always been a big mystery to the plan, is how much 340B opportunity is actually available to the plan. It's been a bit of a mystery to us.
It is. 340B is exploding out in the real world. So thank you so much for your answer.
Okay. No further questions being seen. Is there any other business to come before the committee at this time? Delegate Hamilton, or Senator Hamilton. I slipped again. I knew you guys back in the old days.
There you go. Due to increased costs in our senior centers for fuel prices, I think we should make a note for future meetings to have some people in to give the senior centers some relief on their increased fuel costs, not only for the senior center, but for their employees that going in to do these home visits.
I think the delegate raises a good point, and I'll have this committee staff put that on a subsequent meeting.
Thank you.
Any other business to come before the committee at this time? None being seen, the chair looks to the co-chair for the purpose of a motion.
Chairman, I move we adjourn.
Senator Azinger moves that we adjourn. All those in favor of this gentleman's motion, please signify by saying aye.
Aye.
Those opposed, no.
Yes, sir.
The ayes appear to have it. The ayes do have it. I declare the meeting adjourned.